Yeah, I didn't even see you there. I'm just rushing around like a nut.
It's been slow today. Here we go. We're good.
Hey, good afternoon and welcome to the Insurance and Pharmaceuticals Subcommittee of the Health and Government Operations Committee. We have a very limited amount of time today. We must stop this subcommittee meeting at 1:55. So I would ask people to be concise in their remarks and in their responses to questions. We are discussing 3 bills today. I'm going to do them in this order. We're going to start with House Bill 1339, and then we're going to go to House Bill 1259, and then we're going to go to House Bill 1056. So, House Bill 1339, Health Insurance Hearing Aids for Adults Coverage, Delegate Riley's bill. Lisa, would you tell us a little bit about the bill?
Sure. This bill requires carriers to provide coverage for all medically appropriate and necessary hearing aids for an adult covered under a policy or contract. Carriers may limit the benefit to $1,400 per hearing aid for each hearing impaired ear every 36 months. An insured or enrollee may choose a hearing aid that is priced higher than the benefit limit and pay the difference. There is an amendment that was distributed that specifies that for hearing aids to be covered under the provisions of the bill, they must be prescribed, fitted, and dispensed by a licensed audiologist.
Okay, is Delegate Riley here?
Yes.
Great.
I'm here.
Thank you. Delegate, you want to
Hi.
speak to the bill? And thank you for your work on it, by the way.
Oh, thank you. Thank you. As I said, I got great advice from all my colleagues, especially the chair. So as Lisa said, we worked it out with MHCC, we worked it out with MIA, and we worked it out with the carriers. And everybody likes the current language of the bill with the amendment. And hopefully we can move it forward. And the Senate Finance Committee passed it out of their committee already, or out of so.
In the same form?
Yes.
Okay, great. Thank
And
you.
I think Matt might have a couple words to say as well.
Matt, do you have a couple of words for us? Matt
A couple of words, or thank you, Delegate Riley, for working with us.
Those are good words. We like those words. Seeing no one else's hand raised, I'm going to ask if I have a motion on the amendment.
Move the amendment.
Move the amendment. Second.
Okay, I've got a motion and second. Any discussion on the amendment? Okay,
It's
seeing
favorable.
none. I've got a favorable with amendment. Do I have a second?
Second.
Okay, I've got a second. Any discussion on the bill as amended? Okay, seeing none. Those in favor, please say aye.
Aye.
Will there be any opposition to the bill? Raise your virtual hand. Seeing none, it passes unanimously. Thank you very much.
Thank you, Matt.
You're welcome. Let's move to House Bill 1259, Health Insurance Breast and Lung Cancer Screening Coverage Requirements, Delegate Alston's bill. Lisa, what's it do for us?
This bill expands the current prohibition on cost sharing for coverage of supplemental breast examinations to include image-guided breast biopsy. The current mandated health insurance benefit for coverage of recommended follow-up diagnostic imaging to assist in the diagnosis of lung cancer is clarified to include lung cancer screenings. Such coverage may not require prior authorization. There are amendments that were distributed that clarify the prohibition on prior authorization for lung cancer screening or follow-up diagnostic imaging for lung cancer. And then they removed the exception for high deductible health plans for lung cancer screening because it is already included in the IRS rules for preventative care.
Excellent. Delegate Alston, is she here? Delegate Alston, are you here? Okay, seeing no one. Is there anyone who would like to comment or ask a question on this bill? Matt Celentano.
Thank you, Madam Chair, members of the subcommittee. I appreciate the opportunity. The carriers in general are totally fine with the coverage additions, including the image-guided breast biopsy, follow-up screening, the lung cancer screening. But we would like to, if it is the choice of this committee, to retain the ability to do prior authorization on some of these services. As you all know, and from some of the discussions we've had over the couple of years, and especially this last 15 months or so, when there's a choice there between a diagnostic ultrasound, an MRI, computed topography, image-guided biopsy, these types of services, the carriers would like the ability to continue to work with the physician to make sure that the best service with the best healthcare outcome is going to go to that actual particular insured or beneficiary. Sometimes we actually advise the doctors to go to a higher cost point service, contrary to what you might have heard in the past, because it has better medical effectiveness. And I want to reassure everybody here too, because of the dovetailed nature of the prior authorization discussions in the omnibus larger bill, that there's not going to be delays that you might have heard about in the past, because for an emergency service, it will have to be done in 24 hours, and for a non-emergency service, it will have to be done in 72 hours. So for the best possible care and to make sure that we're not wasting our time and or the financial side for the patients, we would request to be able to keep the prior authorization ability for the carriers. I'm sorry. Thank you very much, Madam Chair.
Okay, thank you. Is there anyone here from the Department of Health? Okay, seeing no one, I'm going to go to, I just know that, and I respect what you've said, Matt, and understand the concern. However, we did, and I see Jason is here. Jason, you want to speak specifically to that?
I can speak. At least we had reviewed the proposed amendments on the bill. Sorry, thank you, Madam Chair. We have reviewed the amendments and we were okay with them, but I know that if there's more discussion that needs to be had, we're happy to have that. But I do know that we reviewed and we were okay with the amendments.
So I did notice in the letter that MDH sent, they raised concerns about the prior authorization. So being a barrier to the service. I just wanted to clarify that. Is that still the position of the health department?
To my understanding, yes, that is still our position. We do still have concerns.
Okay, I will go to Danielle Varanian.
Thank you, Madam Chair. I'm here on behalf of the MRS, Maryland Radiological Society, and RadNet. The only concern that we have about what Mr. Celentano is suggesting is that these prior authorizations can be a barrier for people to get these very needed screenings and diagnostic imaging studies done. So our concern about removing that from the bill is we are worried that that would cause downstream negative impacts on particularly communities where there's people of color getting these necessary studies done.
Thank you. Matt, you're going to get one more bite at the apple.
First and foremost, I want to thank Danielle for getting my name correct. So cheers to you, Danielle. It doesn't happen very often, so I like to point it out.
I'm an Italian, Matt.
Yeah,
so
I know. Kudo. I would just say I have not seen the letter from the health department, and I just wanted to point out too is we all know the prior authorization discussion has been going on a long time, and we don't see it's going to be a barrier to access or for outcomes because of the shortened time frames that are going to be along with services. I would love to see the MDH letter. It is very, very non-traditional for the health department to opine on commercial coverage in the insurance article. So I would love to see it, but that would be a first for me in this role. So with that, thank you for the opportunity to be able to speak.
Thank you, Mr. Celentano. Any further discussion on this issue? And Lisa, you said there were amendments on the bill. Is that correct?
Yes.
Okay.
There are the amendments that clarify that the prohibition on prior authorization, it just is clarifying language for that. And then it removes the exception for the high deductible health plans for lung cancer screening because it's already recognized as a preventative care.
Okay. So do I have a motion on the amendments?
Move the current amendments.
Okay, got the amendments. Second, any further discussion on the amendments? Okay, seeing none, those in favor of the amendments, please say aye.
Aye.
Those opposed, please, is there anyone opposed to the amendments other than Matt? Okay, seeing none, it passes unanimously. Do I have a motion on the bill as amended?
Motion as amended,
Okay, I got a motion favorable.
favorable as
A
amended.
second?
Second.
Okay, moved and seconded. Any further discussion on the amendment? All right, seeing none, all those in favor, please say aye.
Aye.
Any opposition to this bill as amended? Raise your hands. Okay, seeing none, it passes unanimously. Okay, we move to House Bill 1056, State Board of Pharmacy, Prohibition on Discrimination Against 340B Drug Distribution. And that is Lisa. Oh, and the Delegate Gazzoni is the sponsor, but Lisa, you tell us first.
As introduced, this bill prohibits a 340B manufacturer, wholesale drug distributor, third-party logistics provider, and their agents or affiliates from directly or indirectly denying, restricting, prohibiting, discriminating against, or limiting the acquisition or delivery of a 340B drug to a pharmacy on behalf of a covered entity. There are some exceptions in the law. There were 3 amendments that have been distributed, and then one reprint that I distributed that had all the amendments in it, just in case you want to see how they would fit together. The first amendment is 643226/1. It clarifies that the provisions of the bill only apply to 340B manufacturers, but that an investigation of a violation of the provisions of the bill may include a wholesaler or third-party logistics provider. The second amendment, amendment number 413123/1, clarifies that alleged violations committed by a person that is not licensed or permitted by the board will be investigated by the Consumer Protection Division of the Attorney General. And the third amendment, amendment number 943926/1, requires MDH and the Prescription Drug Affordability Board to study the implementation and impact of the bill.
Okay, thank you, Lisa. Delegate Gazzoni, would you like to speak to your bill?
Just want to thank everybody for their work on it, and remind folks that this is really an effort to ensure that both 340B hospitals and community health centers are not limited to just having 1 or 2 contract pharmacies that they can work with, which obviously impacts a lot of folks that may not have an easy time getting to pharmacies.
Okay. So I'm going to look to questions, Delegate Kipke, or comments.
Thank you. Just a quick question. So I'm trying to understand the amendments. I'm looking at them in front of me. There's 3 amendments. Do any of them address, obviously the program is for people who don't have coverage or have limited means that are being treated through a federally qualified health center. And I guess the opposition raised concerns that the spread that, they're allowed to, the health center, the clinics are allowed to keep the spread to help with operating costs. But there were worries that others who aren't really intended to for this program, that they may end up keeping that spread. Do any of these amendments address that?
No, none of these amendments address the cost sharing between the entities in the program.
Not
Okay.
directly, but I'm guessing that the study might, to the extent that they are able to look at that, include that.
Yeah,
Okay.
that's true.
Thank you.
Delegate Shalega?
Thank you, Madam Chair. Yes, I think I said
in another meeting that I'd spoken with some of our federal partners about this program to try to have a better understanding of what it is. And I mean, we want the focus of it to be on helping people who can't afford their drugs. But potentially, could we put some better language in the study at the end of page 4, where we could ask for something like information on all 340B revenue, program 340B program revenue and locations, because I hear some information that some of our hospitals may be partnering with some pharmacies. We might not expect that to be happening, and it just would be good to know the full scope of how this program is being used.
Delegate, where do you see that fitting into the bill?
At the bottom of page 4, where you have the Maryland Department of Health and
Yep.
Prescription Drug Affordability Board conduct a study. So within that study, I think it would be good to get a fuller understanding of this program with actual information about, you know, let's not picking on anybody specifically, but let's say Johns Hopkins Hospital, you know, is getting X millions of dollars from the 340B program through their pharmacies at the downtown center, the Howard County Center, you know, some pharmacies somewhere else. And then we can kind of get a better handle on how this program is being used.
Let me ask Lisa and Delegate Szeliga if this would kind of help with that. So in that line, conduct a study on the implementation. If we did implementation, comma, impact, comma, and financial aspects of section 1, would that get, Lisa, that's not artful, I know. You may have a better way to put it. But would that be that's the concept, right?
Yeah, and the next line says covered entities and 340B manufacturers. So I don't know if covered entities means the facilities.
It's the FQHCs.
Okay, and there's
Those are the
other,
covered
it's not just FQHCs, which I have a hard time putting those consonants together, sorry.
Right.
But those consonants, you know, it's more than them, because hospitals, I think probably every hospital in Maryland is using it as well.
Right, hospitals also, community providers like healthcare for the homeless. But let me move on. I've got a number of folks expecting we may not be able to vote on this today, which means we will have another meeting. I expected to have one anyway, but let's get the discussion going here. Delegate Gazzoni, do you want to respond directly to that? Delegate
Yeah,
Gazzoni?
and yes, I'm sorry. I put myself, am I frozen? I'm frozen.
Yeah, you're just off video, but we can hear you.
Okay, I turned off my video to help the freezing part. So first of all, I don't believe that all hospitals in Maryland are part of the 340B program. I'm fine with the changes. Adding financial information, it's always tricky to get that kind of information. So who knows what we might end up with there, but that's fine with me.
Okay, so you would consider that concept a friendly amendment?
Friendly enough, yes.
Okay. Okay. All right. Thank you. I'm going to go to Delegate Johnson before I go to the folks who aren't on the committee. Delegate Johnson.
Thank you, Madam Chair. And piggybacking on Delegate Szeliga's comments in the study, yeah, I would like to see definitely where the reinvestment is going, to make sure it's going in our communities in Maryland that it's supposed to be helping and not out of state.
Okay.
Thank you, Madam.
Delegate Gazzoni, would you consider that friendly as well?
I'd like to defer to either Mark with Powers or Nora with the FQHCs, because I think that they probably have a lot more understanding of exactly how the reinvestment works and what the auditing processes are and that kind of thing, because I know that their programs are audited.
Okay, then I'm going to go to Nora then. Nora Hoban.
Great. Thank you so much, Delegate Collison. So The audit program is at the federal level and it is working. We have 8 hospitals that have been audited with clean audits. 1 did have a finding and had to pay the money back to pharma. So I think at the national level, those audits are working really well. And we do have some really good examples of I think what the request is asking for. Hopkins in particular has fantastic reports that are easily accessible on their website. And they say, here's how much revenue was generated from 340B and here's all of our investments. So I think there's ways to do that are probably already happening. And if it's an ask across the board, maybe that's something. I would be careful of how much the audit responsibility does lie with the federal government. I don't think we need to change that since it is really effective in Maryland. But those are my thoughts.
I think what I hear the committee members saying, though, is that we want information specific to Maryland. And if we open this up beyond hospitals, then we want a good sense of where the money is, how the money is being spent. We could, in this study, use the federal information to learn that. So we can just include that in what the state looks at. I don't know that it hurts us to ask for the information. Okay, I'm going to go to Mark Ogunsusi.
Yep, thank you.
Uh-huh.
And I'll keep it quick. I just want to flag that hospitals are already subject to onerous transparency requirements. They have to submit Medicare cost reports where the disproportionate share of Medicaid and Medicare individuals that the hospitals serve is reported. It's submitted to the federal government and is accessible. Additionally, just really quickly, hospitals have to submit, because they're nonprofit and governmental, have to submit Form 990s to the IRS, where the hospital's undercompensated services are reported, analyzed, and reviewed. Hospitals have to submit a financial needs assessment, which is public and available to the committee. Additionally, hospitals have to verify patients that are eligible for financial assistance for emergency care. So from my review of the available data, 80% of Maryland's 340 hospitals, of Medicaid services rendered to Medicaid recipients in Maryland are by 340B hospitals. So, I support transparency. We've always been supportive of transparency. We thank you for the friendly amendments, but I'd just like to direct the committee's attention to the fact that the hospitals already provide this important data. One more point, contract pharmacies that are signed up for each hospital are publicly available on HRSA's Office of Pharmacy Affairs Information System. So to the point of the delegate of knowing where the pharmacies are contracted, that's all currently publicly available, consistent with Ms. Hoban's explanation of the current federal program. And one final point is just for the committee's understanding, the 8th Circuit opinion just came out today and Arkansas's law was upheld. So I just want to reiterate that you're within your power to regulate public health.
Okay. All right, thank you. Jason Kaplan.
Thank you, Madam Chair. We with the department, after reviewing the amendments, believe that the study should be more aptly placed with the Prescription Drug Affordability Board with the department in consultation, as we have limited expertise in this area and believe that the board would be better suited to take ownership of the study as a whole. And we have spoken with the board on that, and they were okay with that.
Thank you. I'm just gonna affirm that with the executive director, Mr. York.
Thank you, Delegate Collison. Yeah, I think that would be fine. We don't have a lot of we have a lot of insights in terms of like national information. The Maryland specific information, we may need Medicaid's help to parse through some of the claims data, because often the 340B flag is not available in all claims data. I know one of the previous testimonies in the original legislation was just talking about how there is some sort of flag submitted on the pharmacy claims. So it's just a matter of kind of tracking that down. So we can work with Medicaid on that.
Great, thank you. I am going to take Kristen Parday, Steve Johnson, and then Nora Hoban, and then we're going to stop. We are going to have this bill in the next meeting. Kristen, want to go ahead?
Yes, thank you, Madam Chair. We are here with Pharma in opposition to the legislation for some key reasons. One is this is a federal program, often not realized is it's the second largest federal prescription drug program right after Medicare Part D. We believe it needs comprehensive reform. We're part of a coalition working on that at the federal level. We also believe that this type of legislation really codifies one of the biggest issues with the program right now, which is a lack of transparency, where you have a situation where a lot of large hospital systems, contract pharmacies, as well as PBMs have really been able to utilize the system to create a lot of profits. And while that needs to be looked at from a federal level, codifying it at the state level, this one element we don't believe is helpful to the program. I just wanted to quickly address two things. Is yes, you can receive all of the information on the hospitals on the website that Mark mentioned. And so it is most of the hospital systems in Maryland. And I'm happy to share that. I have it on a spreadsheet. I'm happy to share that with everyone if they'd like. And as far as auditing, I do want to clarify that HRSA is in charge of auditing. That is a federal role since this is a federal program. But of the about 20,000 different covered entities across the country, you look at about 200 audits a year. So it is a pretty limited amount, keeping in mind that HRSA is a relatively small organization for what is become a gigantic program since its inception.
Great. Thank you. Thank you for your information. Delegate Johnson.
Thank you, Madam Chair. I heard a lot about audits, the federal audits on the hospitals. Do they also cover the pharmacies that are merged or contracted with the hospitals?
I don't know. Andy, do you have that information?
I don't have that off the top of my head, but I can find that for you.
Okay. Maybe Nora, do you have it?
Mark does.
Yeah, really
Okay.
quickly, HRSA audits claims, prescriptions that are filled at contract pharmacies. That's part of HRSA's audits. Pharmacies are also subject to Medicaid managed care payer audits. They're subject to private payer PBM audits. The pharmacies are audited by the Board of Pharmacy, but for 340B, the payers are auditing the pharmacy and the federal government is auditing the pharmacies for the correct utilization. Most of the, if you ever see diversion, is going to be related to drugs dispensed at a contract pharmacy. HRSA audits those contract pharmacies. 200 audits a year. Diversion of non-patients has decreased 50% over the past 10 years. However, manufacturers overcharging covered entities has increased. 4 out of 5 manufacturers audited overcharged covered entities in 2022.
Thank you.
Okay, thank you. I'm going to take Delegate Shalega and then we are going to have to stop. So please know we will take this up again at our next meeting, which I can't tell you when it is right now. So watch your emails. Delegate Shalega.
With regards to what we're talking about, we talked about hospitals and pharmacies. What about PBMs? I'm not sure how they interact with the 340B, but if they have if they're getting money out of the program as well, it would be good to have the information about how they're doing it and where that money's going.
Okay. All right. We know some things we need to think about between now and the next time we meet. We do in 4 minutes, our hearings will begin in HGO. So we need to adjourn for today. Please watch your emails for the next meeting. We do have a couple of outstanding bills that we hope to bring to you at the next meeting.